Hydroceles, a patent process of vaginalis, may allow peritoneal fluid but no intestine to track down to form a hydrocele. Hydroceles are unilateral or bilateral, asymptomatic, non-tender scrotal swellings. Hydroceles may be tense or lax but typically transilluminant. The majority resolves spontaneously as the process continues to obliterate, but ligation and division is recommended in boys over 3 years of age. Rarely a baby can have tense, painful hydrocele warranting early repair. A hydrocele can occasionally extend back up into the canal or abdomen, abdominoscrotal hydrocele. This figure 9.9, a left inguinal swelling. Clinical examination is needed to confidently distinguish a hydrocele from an inguinal hernia. Undescended testes are palpable or impalpable. At birth, 4% of full-term boys have unilateral or bilateral undescended testes, but after 3 months of age, the incidence is less than 1% and it changes little thereafter. The incidence is higher in preterm infants, attributed to the testis descending through the canal in the 3rd trimester. A normal testis reaches the base of the scrotum with a good length of cord above it. Testis cannot be palpated in the inguinal canal but can be milked from there into the superficial pouch, palpable undescended testis, or into the scrotum with a good length of cord, normal. A retractile testis can be manipulated into the base of the scrotum without tension but is pulled up by the cremaster muscle. With time, retractile testes reside permanently in the scrotum. However, follow-up is advisable because rarely the testis ascends back into the inguinal canal. The ascending testis needs an orchidopexy. An ectopic testis lies outside its normal line of descent, often in the perineum. A palpable undescended testis ideally requires a day case orchidopexy between 6 and 12 months of age. The testis is mobilized through an inguinal incision, preserving the vas deferens and testicular vessels. The associated patent processes vaginalis is ligated and divided at the internal ring, and the testis is placed in a subtartose scrotal pouch. Impalpable undescended testes are either absent or located in the abdomen or inguinal canal. There is no benefit from imaging, and these are best managed with a laparoscopy and usually a stage approach. Figure 9.10, laparoscopic view of right-sided intra-abdominal testis visible at the internal ring. Vas single arrow, this is the single arrow vas, and testicular vessels double arrow, these are the testicular vessels. The benefits of orchidopexy include fertility. To optimize spermatogenesis, the testis needs to be in the scrotum below core temperature at a young age. Orchidopexy around 6 to 12 months of age is currently recommended. Fertility after orchidopexy for a unilateral undescended testis is near normal. Men with a history of bilateral intra-abdominal testes are often infertile. Malignancy. Undescended testes are histologically abnormal and at an increased risk of malignancy. The greatest risk is in patients with bilateral intra-abdominal testes. Early orchidopexy for a unilateral undescended testis may reduce the risk, but this is not proven. Cosmetic and psychological. In an older boy, a prosthetic testis can be inserted to replace an absent one. Summary of box 9.7, the undescended testis. A retractile testis reaches the base of the scrotum but retracts. An undescended testis may be palpable or impalpable. An ectopic testis lies outside the normal line of descent. Palpable undescended testis undergo a single stage orchidopexy. Impalpable undescended testis undergo a single stage orchidopexy. Orchidopexy before 1 year of age improves fertility and may reduce the risk of malignancy. The acute scrotum. Testicular torsion is most common in adolescents but may occur at any age and is usually inside the tunica vaginalis. Perinatal torsion differs and is usually extravaginal. The pain is not always scrotal and may be felt in the groin or lower abdomen. Scrotal edema and erythema can be absent. Sometimes there is a history of previous transient episodes. Torsion of the testis must be relieved with 6 to 8 hours of the onset of symptoms for there to be a good chance of testicular salvage. At operation, viability of the testis is assessed after derotation. If salvageable, 3-point fixation of both testes with non-absorbable sutures is performed. Expert assessment of testicular blood flow by color Doppler ultrasound may help in the differential diagnosis, but the scrotum must be explored urgently if torsion cannot be excluded. Torsion of a testicular or epididymal appendage characteristically affects boys before just puberty, possibly because of enlargement of the hydatid in response to gonadotrophins. A hydatid of Morgagni is an embryological remnant found on the upper pole of the testis or epididymis. The pain often increases over a day or two. Occasionally, the tauted hydatid can be felt or seen, blue dot sign. Excision of the appendage leads to rapid resolution of symptoms. Viral or bacterial epididymoarchitis may cause an acute scrotum in infants and toddlers, but this diagnosis is often only made after scrotal exploration. Other conditions can rarely cause acute scrotal symptoms, and signs include idiopathic scrotal edema, typically painless erythematous scrotal swelling in a young boy extending off the scrotum into the groin and towards the anus, an incarcerated inguinal hernia, vasculitis, or a scrotal hematoma. Figure 9.11, acute scrotal pathology at different ages. So these are the ages in the axis is given in years, 0, 5 and 10. So the hydatid torsion, the incidence is more likely to be around 10 years, and testicular torsion is most likely to happen around 15 years of age. Summary 9.8, diagnosis and treatment of acute scrotum. Torsion of the testis must be assumed until proven otherwise. Testicular torsion can present with acute inguinal or abdominal pain. Urgent surgical exploration is crucial if testicular torsion cannot be excluded. If torsion is confirmed, an occipitopexy should be performed on both sides. Torsion of a testicular appendage usually occurs just before puberty. An incarcerated inguinal hernia must be considered in the differential diagnosis. The penis, hypospadias. In hypospadias, seen in 1 in 300 boys, the urethra opens proximally and ventrally. Most commonly, the opening is just proximal to the glans, but it can open on the penile shaft or onto the perineum. It is attributed to failure of complete urethral tubularization in the fetus. The foreskin is deficient ventrally, and there is a variable degree of chordae, ventral curvature of the penis, most apparent on erection. Glandular hypospadias needs correction for cosmetic reasons, but more proximal anomalies interfere with micturition and erection. In a newborn with severe hypospadias and bilateral undescended testis, disorders of sexual development should be considered. Distal hypospadias is usually repaired before 2 years of age in 1 or 2 stages. Proximal varieties require complex stage procedures. Surgery aims to achieve a terminal urethral meatus so that the boy can stand to micturate with a normal stream, a straight erection, and a penis that looks normal. Ritual circumcision is contraindicated in infants with hypospadias because the foreskin is often required for the reconstruction. The foreskin and circumcision. At birth, the foreskin is adherent to the glans penis. These adhesions separate spontaneously with time, allowing the foreskin to become retractile. At 1 year of age, about 50% of boys have a non-retractile foreskin. By 4 years, this has declined to 10%, and by 16 years to just 1%. Ballooning of the normal non-retractile foreskin on micturition brings many young boys to doctors, and explanation and reassurance are required but no operation. Gentle retraction of the foreskin at bath times helps to maintain hygiene, but forcible retraction should never be attempted. The presence of perpetual adhesions when the foreskin remains partially adherent to the glans is normal and resolves spontaneously. Smegma pearls accumulating under the foreskin are commonly mistaken for tumors. Reassurance is needed. We'll see the diagram. Figure 9.12, hypospadias, note the hooded foreskin and the ventral meatus. Circumcision has been an important tradition in Jewish, Muslims, and other cultures. Proponents observe that circumcision reduces the incidence of urinary tract infection in infants, boys. However, circumcision is not without risk of significant morbidity. The medical indications for circumcision are phimosis. This term is often wrongly applied to describe a normal, non-retractile foreskin. True phimosis is seen as a whitish scarring of the foreskin and is rare before 5 years of age. It is caused by the localized skin disease Balanitis xerotica obliterans, BXO, Balanitis xerotica obliterans, which also affects the glans penis and can cause urethral meatal stenosis. Recurrent balanoposthesis, recurrent balanoposthesis, a single episode of inflammation of the foreskin, sometimes with a purulent discharge, is not uncommon and usually resolves spontaneously. Antibiotics are sometimes needed. Recurrent attacks are unusual but may be an indication for circumcision. Recurrent urinary tract infection. Circumcision is occasionally justified in boys with an abnormal upper urinary tract anomaly and recurrent urinary infection. It may also help boys with spina bifida who need to perform clean intermittent urethral catheterization. An emerging but controversial indication for circumcision is in the prevention of sexually acquired human immunodeficiency virus (HIV) infection in communities where this is common. Large clinical trials have shown that circumcision reduces the risk of HIV transmission. Circumcision for medical reasons is best performed under general anesthesia. A long-acting local anesthetic regional block can be given to reduce post-operative pain. Circumcision is not a trivial operation. Bleeding and infection are well-recognized complications, and more serious hazards such as injury to the glands may occur if the procedure is not carried out well. Summary: circumcision medical indications are BXO and recurrent melanocystitis, paraphimosis, scarring from trauma. Circumcision is not indicated for an otherwise healthy non-retractile foreskin. Complications include bleeding, poor osmosis, too much or too little skin removed, and trauma to the glands or urethra. We'll see the diagram given over here. 9.13, true phimosis from Balanitis xerotica obliterans. This is a structure at the umbilicus. So we can see on the right side upper corner there is the ileum with Meckel's diverticulum shown. The blue color structure is falciform ligament. This is the umbilical cord through which we can see falciform ligament, umbilical vein going, then becomes median umbilical fold. There is a bladder down which becomes median umbilical fold upwards. Umbilical artery goes upwards. There is the umbilical ring, allantois urachus. Midline hernias. In the embryo, the umbilical ring is a relatively large defect in the ventral abdominal wall, transmitting several structures that connect the fetus to the placenta. An umbilical hernia is common and caused by incomplete closure of the umbilical ring. Incarceration is very rare. Most umbilical hernias resolve by 4 years of age. Supraumbilical hernias occur through defects in the linea alba just above the umbilical ring and do not close but are still repaired at around 4 years of age. Epigastric hernias are defects higher still that allow a small amount of preperitoneal fat to prolapse. They are repaired if symptomatic. Infantile hypertrophic pyloric stenosis. Infantile hypertrophic pyloric stenosis presents with non-bilious projectile vomiting between 2 to 8 weeks of age and is only rarely seen after 13 weeks. It is easily distinguished from many other serious causes of vomiting such as infections because the baby is particularly hungry. Infantile hypertrophic pyloric stenosis is a progressive condition, and a detailed history helps distinguish it from the more common gastroesophageal reflux, which is commonly seen in infancy. In the United Kingdom, it affects 1 to 300 infants with a male to female ratio of 4:1. However, if a girl has IHPS, her offspring have a high chance of developing it, suggesting a genetic predisposition. Non-bilious nature is stressed here to contrast the condition with the bilious vomiting of the potentially life-threatening malrotation and volvulus seen occasionally in neonates. IHPS can be diagnosed clinically. During a test feed, there is visible gastric peristalsis passing from left to right across the upper abdomen, and in a relaxed baby, the pyloric tumor is palpable as an olive in the right upper quadrant. The diagnosis can be confirmed by an ultrasound which shows the thickened pyloric muscle. Infantile hypertrophic pyloric stenosis is readily treated by surgery, but the infant must be adequately rehydrated and the hypokalemic alkalosis corrected. This may take 48 hours if the chloride is 85 millivol per liter or lower. In most babies, the dehydration and alkalosis can be corrected by giving 150 to 180 milliliter per kg per day of 0.9% saline with 0.15% KCl in 5% glucose. Oral feeding is discontinued and the stomach emptied with 8 to 10 French nasogastric tube. Ongoing gastric losses should be replaced intravenously. Ramsted's pyloromyotomy is performed by a laparoscopic or open supraumbilical incision. A serosal incision is made and the tumor spread. The end result should be an intact bulging submucosa from duodenal fornix to gastric antrum. Perforation of the duodenal fornix is uncommon and not serious provided that it is recognized and repaired immediately. Post-operatively, intravenous fluids are continued until oral feeding is re-established within 24 hours. Occasionally, the baby has small vomits on the first few feeds, but this resolves after 72 hours. If it persists, then an incomplete myotomy or gastroesophageal reflux should be considered. Surgical complications include duodenal perforation, hemorrhage, wound infection, and wound dehiscence. All are uncommon and avoidable. Pyloromyotomy has no significant long-term sequelae. Infantile hypertrophic pyloric stenosis most commonly affects boys aged 2 to 8 weeks. Projectile vomiting after feeds, test feed or ultrasound to confirm the diagnosis. Gastric peristalsis can be seen and an olive felt on the right upper quadrant. Hypokalemic metabolic alkalosis must be corrected before surgery. Pyloromyotomy splits the hypertrophied muscle, leaving the mucosa intact. This is the pyloromyotomy. You can see the incision given for infantile hypertrophic pyloric stenosis. Other common or serious causes of vomiting in infancy are shown in the figure, shown in the table 9.4. Gastroesophageal reflux is common and tends to resolve spontaneously with maturity. Persistent symptoms respond to thickened feeds and anti-reflux medication. Complications such as failure to thrive or respiratory problems demand further investigation and in some cases laparoscopic fundoplication. Vomiting in infancy. If it's bile stain in neonates and older infants, in neonates, intestinal malrotation with volvulus, as I'll explain a bit, as there is the opening of the bile duct and the pancreas into the second part of the duodenum. Any causes of obstruction beyond this point of second part of duodenum will lead to a bile stained vomiting. So in neonate, intestinal malrotation with volvulus, duodenal atresia or stenosis, Down syndrome antenatal diagnosis, jejunal or ileal atresia, often isolated anomalies, Hirschsprung's disease, anorectal malformations, meconium ileus, cystic fibrosis, necrotizing enterocolitis, and acquired condition in premature incarcerated inguinal hernia. Older infants, intestinal malrotation with volvulus, intussusception, often non-bilious initially, incarcerated inguinal hernia, now non-bilious vomiting, which will be a more proximal to the second part of duodenal defects. So first one is infantile hypertrophic pyloric stenosis, gastroesophageal reflux, feeding difficulties, technique of volume, non-specific markers of illness, example, infection, urinary tract infection, meningitis, gastroenteritis, respiratory metabolic disorders, raised intracranial pressure, congenital adrenal hyperplasia. Intersusception. Most intersusceptions in children occur from 2 months to 2 years of age. They are life-threatening. Intersusception typically causes a strangulating bowel obstruction, which can progress to gangrene and perforation. Intersusception is classified according to the site of the intersusceptum and intersusceptions. In children, more than 80% are ileocolic, beginning several centimeters proximal to the ileocecal valve, with their apex found in the ascending or transverse colon. In the majority, the cause is hyperplasia of Peyer's patches, lymphoid tissue, which may be second to a viral infection. In 10% of children, there is a pathological lead point such as a Meckel's diverticulum, enteric duplication cyst, or even a small bowel lymphoma. Such cases are more likely in children over the age of 2 years and in those with a recurrent intersusception. Classically, a previously healthy infant presents with colicky pain and vomiting milk-like bile. Between episodes, the child initially appears well. Later, they may pass a red currant jelly stool. Clinical signs include dehydration, abdominal distension, and a palpable sausage-shaped mass in the right upper quadrant. Rectal examination may reveal blood or rarely the apex of the intersusceptum. Presentation of intersusception. Bilious vomiting in an infant is a sign of intestinal obstruction until proved otherwise. Intersusception classically presents with colicky pain and vomiting. Intersusception should be considered in any infant with bloody stools. Age range is between 2 to 24 months of age. Plain radiograph is rarely requested, but if done, is commonly shown signs of small bowel obstruction and a soft tissue opacity. Diagnosis is confirmed on an abdominal ultrasound. Ileocolic figure 9.16. Ileocolic intersusception causing small bowel obstruction. We can see the intersusception. In the left part, the intersusceptum goes inside the intersuscipiens, which is shown on the right side, which covers the left part. After resuscitation with intravenous fluids, broad spectrum antibiotics, and nasogastric drainage, non-operative reduction is attempted using an air enema. Successful reduction is recognized if air flows into the small bowel together with later resolution of symptoms and signs. An air enema is contraindicated if there is peritonitis, perforation, or shock. More than 70% of intersusceptions can be reduced non-operatively. Strangulated bowel and pathological lead points are unlikely to reduce. Perforation of the colon during pneumatic reduction is a recognized hazard but is rare. Recurrent intersusception occurs in up to 5% of patients after non-operative reduction. Operative reduction can be performed open or laparoscopically. The intersusception is milked distally by gentle compression from its apex at an open procedure. Both the interseptum and the intersecipients are inspected for areas of non-viability. Any irreducible interseption or one complicated by infarction or a pathological lead point requires resection in primary anastomosis. We'll see figure 9.17, erythema reduction of interseption. The arrows mark the soft tissue shadow of the interseptum. And interseptum is part which goes inside the intersecipients. Management of interseption. Bowel infarction will result without treatment. Most are ileocolic. Diagnosis can be confirmed by ultrasound scan. Fluid and electrolyte resuscitation is essential. Most interseptions can be reduced non-operatively using an air enema. If there are signs of peritonitis or perforation, then an emergency operation is needed. Acute abdominal pain in children over 3 years of age. Between 1/3 and 1/2 of children admitted to hospital with acute abdominal pain have non-specific abdominal pain. The term mesenteric adenitis is unhelpful and should be dropped. Another 1/3 have acute appendicitis. Relatively benign conditions such as constipation and urinary tract infections account for most of the remainder. A small proportion of children have more serious pathology. History and examination. Time and patience are required to evaluate the child with acute abdominal pain accurately. The child may be frightened and the parents worried. Young children find it difficult accurately to describe or localize abdominal pain but can often give a good history. The abdomen, genitalia, chest, throat and neck are examined. The abdomen may need a reassessment after analgesia and a number of reviews. A gentle abdominal examination of the sleeping toddler before removing their clothes may reveal tenderness, guarding or a mass. Rectal examination is only performed if a pelvic appendicitis is suspected by the surgeon, whose decisions will be altered by the findings. Active observation acknowledges that a definitive diagnosis is not always possible when the patient is first seen. The surgeon reassesses the child after a few hours while rehydrating with IV fluids or allowing clear fluids and simple analgesics. This approach reduces the need for investigations and can reduce the negative appendectomy rate to as low as 4%. Ultrasound and CT scans have a role in selected children. Workup of children with acute abdominal pain. A careful history and examination and active observation are paramount. Routine tests include full blood count, C-reactive protein, urine analysis, microscopy and culture. Abdominal ultrasound scan, not mandatory initially but may be useful. Other tests may be helpful after a period of observation. Abdominal ultrasound scan can diagnose pelvic and urine tract pathology. Occasionally helpful tests, a plain supine abdominal radiograph, particularly in the preschool children with pain and vomiting, ultrasound or CT scan in complex cases. Selective specific investigations, blood culture, stool culture, plasma amylase, diagnostic laparoscopy. Acute non-specific abdominal pain. The clinical features of non-specific abdominal pain are similar to those of acute appendicitis, but the pain is poorly localized, non-aggravated by movement and rarely accompanied by guarding. The site and severity of maximum tenderness often vary during the course of repeated examinations. Symptoms are typically self-limiting within 48 hours. The etiology of non-specific abdominal pain in children is obscure, but viral infections and transient interception account for some cases. Viral infections can cause reactive lymphadenopathy, fever and diffuse abdominal pain. In some children, recurrent acute abdominal pain can be organic or sometimes an expression of underlying psychological problems or abuse. Acute appendicitis and its pitfalls. Classically, there is anorexia and few vomits with central abdominal pain which settles in the right iliac fossa. In early acute appendicitis, there is a fever of 37.3 to 38.4 degrees Celsius and localized tenderness. Finding persistent guarding in the right iliac fossa on repeated examination is the key to making the diagnosis and distinguishing it from non-specific abdominal pain, which usually resolves over 24 to 48 hours. Non-specific abdominal pain does not have the persistent guarding. Acute appendicitis was principally always a clinical diagnosis, but more recently, early ultrasound is proving useful. Investigations may help but cannot replace regular expert clinical review. The pitfalls include wrongly making the diagnosis of gastroenteritis when there are loose stools or attributing pain on micturition and pyuria to a urinary tract infection. Both of these can occur when there is a pelvic appendicitis or a pelvic collection. Referred pain from a right lower lobe pneumonia should be considered, and it is important to remember that if antibiotics have been given, the signs may be reduced and presentation can be delayed. The diagnosis can be difficult in those under 5 years of age. Many under 5s present with a perforated appendix, not because the diagnosis is made late, but rather because the omentum is less well developed and inflammation is not well contained. The treatment starts with resuscitation with intravenous fluids, analgesia, and broad-spectrum antibiotics. Appendectomy can be performed laparoscopically or through a muscle-splitting right iliac fossa incision. An appendix mass in a child who is not obstructed may respond to non-operative management with antibiotics, and an interval appendectomy can be considered 6 weeks later. Acute appendicitis, anorexia, vomiting, low-grade fever, tenderness and guarding in the right iliac fossa, exclude referred pain from right lower lobe, pneumonia. Surgery is the treatment of choice after resuscitation and antibiotics. The causes of acute abdominal pain in children: intestinal obstruction, consider interception, inguinal hernia, adhesions and Meckel's diverticulum. Constipation, often overdiagnosed as a cause of acute abdominal pain, particularly as the plain X-ray of dehydrated ill child frequently shows fecal loading. Urinary tract disorders. UTI is an uncommon cause of acute abdominal pain. Urinary symptoms, fever and vomiting tend to predominate. Urine analysis, microscopy and culture are useful, but a sterile pyuria may accompany acute appendicitis. Children with pelviureteric junction obstruction can present with acute or recurrent abdominal pain and no urinary symptoms. Gastroenteritis may cause colicky abdominal pain. Onset of pain before the diarrhea and the presence of lower abdominal tenderness should raise the suspicion of appendicitis. Tropical diseases, ascariasis, typhoid and amoebiasis can cause acute abdominal pain. There are numerous rarer causes of acute abdominal pain in children, including Henoch-Cholin purpura, sickle cell disease, primary peritonitis, acute pancreatitis, biliary colic, testicular torsion, gynecological pathology, example, ovarian cysts and tumors, pelvic inflammatory disease, hematometrocolpos, and urinary stone disease. Rare causes of acute abdominal pain in children: obstruction from intussusception, adhesions, Meckel's diverticulum, and an inguinal hernia, constipation, urinary tract disorders, gastroenteritis, ascariasis, typhoid. Urinary tract infection. UTIs in children may be due to a urinary tract abnormalities which may carry a risk of developing renal scarring from ascending infections. Infection and obstruction are particularly hazardous. Older children complain of dysuria and frequency, whereas infants presenting with vomiting, fever and poor feeding. Urine specimens from children are easily contaminated during collection and results must be interpreted with care. A proven infection is investigated by an ultrasound scan. Micturating cystography and radioisotope renography are helpful in excluding vesicoureteric reflux and renal scarring. Treatment aims to relieve symptoms, correct causes and prevent renal scarring. Vesicoureteric reflux may resolve spontaneously. Some may need antibiotics, prophylaxis, or in a very small number of cases an endoscopic treatment or a reimplantation of the ureter. Children with neuropathic bladders, spina bifida, are at risk of secondary upper renal tract complications. Management of these children must take into account their dexterity and motivation. An adequate capacity low pressure bladder can frequently be managed by clean intermittent catheterization, but a high pressure bladder is hazardous and other strategies such as bladder augmentation may be necessary. Some of these children empty their bladder via a non-refluxing catheterizable channel fashioned from the appendix, the bowel, or a redundant ureter interposed between the abdominal wall and bladder. Mitrofanov. Anorectal problems. Constipation. The passage of hard or infrequent stools is common in children in the West. Severe constipation may be secondary to an anal fissure, Hirschsprung disease, or an anorectal malformation or a neuropathic bowel. A detailed history and examination of the bowel, anus and spine will identify most causes. Rectal examination and plain abdominal radiography may be helpful in severe cases. In the absence of specific underlying pathology, the child is best managed jointly with a pediatrician using a combination of diet, extra fluids, reward systems and laxatives. Rectal prolapse. Mucosal rectal prolapse can occur in toddlers and is exacerbated by straining or squatting on a potty. It is typically intermittent and frequently self-limiting. Rarely it may be secondary to cystic fibrosis or spinal dysraphism. The differential diagnosis includes a prolapsing rectal polyp. Underlying factors such as constipation should be treated. Recurrent symptomatic prolapse usually responds to injection sclerotherapy. Stabbing the buttock is ineffective. Rectal bleeding. Unlike in adults, malignancies is an exceptionally rare cause of rectal bleeding. In newborns, the life-threatening causes are malrotation and necrotizing enterocolitis, and in older infants and children, intussusception. The quantities of blood loss are small, but conditions are serious. Other causes include anal fissures, juvenile polyps, and certain gastroenteritis, Campylobacter infection. The 4-year-old patient who presents with hemoglobin of 40 gram per liter will most likely have bled profusely from an ulcer adjacent to a Meckel's diverticulum containing ectopic gastric mucosa. The technetium scan may confirm the presence of ectopic gastric mucosa. Figure 9.18, colonic juvenile polyp. These are typically pedunculated. You can see the pedunculated colonic juvenile polyp. Over here we can see figure 9.19, Meckel's diverticulum containing ectopic gastric mucosa. A positive Meckel's scan. Meckel's diverticulum may also be complicated by an obstructing band between the diverticulum and the umbilicus, diverticulitis, intersusception, intestinal volvulus, or perforation. Swallowed or inhaled foreign bodies. Coins are the most frequently swallowed foreign bodies in children. Once beyond the cardia, they are usually passed in a few days. A plain radiograph of the abdomen, chest, and neck should establish the site of radiopaque objects. Esophageal objects can be removed endoscopically under general anesthesia. Button batteries must be removed within hours because if they remain in the esophagus, they can perforate into the trachea or aorta. Batteries in the stomach are either removed urgently or followed very closely with repeat x-rays over a couple of days. The need to remove sharp objects depends on the size, the age of the child, and their position in the gut. Ingested magnets can cause enteroenteric fistulae when they fix to one another in adjacent loops of bowel. Battery ingestion in older children and young people may be a manifestation of self-harm. Inhaled foreign bodies or cause sudden onset coughing and stridor. If there is worsening dyspnea or signs of hypoxia, then the infant should be given back blows in a head down position. Abdominal thrust, Heimlich maneuver, can be used in older children. A foreign body is suggested by a unilateral wheeze, decreased transmitted breath sounds, and hyperinflated lungs from air trapping, or on an expiratory chest X-ray. A rigid bronchoscopy with a ventilating bronchoscope and appropriate optical forceps is needed to assess and remove objects. Figure 9.21, the inspiratory left and right expiratory chest radiographs demonstrating left-sided pulmonary air trapping. Left-sided pulmonary air trapping after inhalation of a radiolucent foreign body. Swallowed and inhaled objects. Most swallowed objects pass spontaneously. Battery needs watching. They must pass quickly if their contents are not to leak. Objects jammed in the airway or esophagus need removing promptly.